Hi, my name is Julia McMillan, and my Gardner Fellowship research project is titled The Semantic Dissonance Surrounding Palliative Care, an Analysis of Ambiguous Terminology and Resulting Death-Related Stigma. Traditionally, palliative care is described as interdisciplinary care that focuses on improving the quality of life for persons of any age who are living with any serious illness. However, most descriptions of palliative care across medical literature are notoriously vague, just as the one I just described. The terms included within these definitions do not clarify whether these services should be initiated at the time of diagnosis or even provided at the same time as curative treatment. My research project highlights how this definitional ambiguity creates confusion surrounding palliative care's target population and perpetuates the stigma that palliative care services are only reserved for those who are dying. Just as hospice care, palliative care was originally introduced as a pain mitigating service for patients dying of cancer. In fact, after hospice care was created by Dame Cicely Saunders in England in 1967, it was brought to Canada by Balfour Mount in 1974 as a nearly identical service. The only difference was that the Canadian service was titled palliative care because hospice was already a French word for nursing home. The terms hospice and palliative care were later grouped together under a medical subspecialty titled palliative medicine, and this grouping eventually led to palliative care's prominence as the all-encompassing term for end-of-life care. These findings are demonstrated in the Google Ngram viewer graph depicted on this slide, as it is evident that palliative care soars above hospice care and palliative medicine in the number of times it has been used in literature between 1970 and 2008. Although more recent studies have shown that palliative care services are being utilized earlier in the disease process, the use of palliative care as a dominant term in medical literature has contributed to its continued association with hospice and has resulted in death-related stigma. The idea that the term palliative care has been used to describe both end-of-life care and pain mitigating practices at any stage of illness is also reflected in its various definitions across medical literature. As can be seen in the table presented on this slide, the use of ambiguous terms such as life-threatening, advanced, life-limiting, serious, severe, and incurable illness to describe the prognoses of patients leads to confusion surrounding palliative care's target population. These terms have been criticized for their ambiguity and leave the severity of qualifying medical conditions up to subjective interpretation. For this reason, the current definitions of palliative care fail to clarify palliative care's relationship with end-of-life care, the use of curative treatment, and the prognosis of those suffering from specific illnesses. In this way, the lack of clarity surrounding palliative care and its definitions has led to a death-related stigma held within society. This stigma has many societal implications and has impacted access to palliative care by perpetuating misconceptions surrounding the service's relationship with death, doctors' unwillingness to refer patients to the service, and reluctance of patients to accept referrals. Both doctors and patients continue to associate palliative care with the end of life, and for this reason, many doctors are uncomfortable discussing this model of care with their patients. Additionally, patients worry that accepting palliative care services will result in a stoppage of their curative treatment and ultimately hasten their death. They may not accept these services even though they are medically necessary. For this reason, we can only begin to reverse the effects of the stigma by educating the public and confronting the semantic dissonance that plagues palliative care. Scholars have proposed a variety of solutions for the ways in which public health officials could begin to rectify the stigma surrounding palliative care. One of these is a complete name change, but scholars have argued that supportive care and patient-centered care are terms that are already widely used in other sects of medicine. Additionally, scholars have argued that basic training in palliative care competencies during medical school could help reduce the stigma, but none of this could be accomplished without a clear definition of palliative care that exists in the first place. Therefore, the most feasible solution to the problem of death-related stigma and the semantic dissonance that exists surrounding palliative care are educational efforts that target the general public and the creation of a universal definition. This new definition should attempt to reduce the confusion associated with palliative care services by outlining specific symptoms, prognoses, and uses of the service. Attempts to overcome the stigma and semantic dissonance surrounding palliative care must be rooted in an effort to create a clear definition of palliative care, as well as educational efforts that extend to all populations in society. As a result of these conclusions, I feel that a restructured definition of palliative care must be released as soon as possible in order to increase access to palliative care throughout America and countries all over the world.